and we'll start off just by introducing ourselves. I think that's the easiest. Many of you probably know each other, but we'll introduce ourselves anyway. I'm Cheryl Levitt, and I'm a family physician, and I'm a professor at McMaster University. And I've been working in quality for about 10 years, and that's enough.
Yeah. I'm Janecke Thesen. I'm a GP, and I also have several other jobs. One small is in research, and one small is in quality, where we try to establish a quality center for supporting family practices doing quality business. But we have so far not been able to charm the authorities the way we wanted to charm. But we are still working.
I'm Olivier Saint-Larry. I'm from France. I'm a GP. I don't know the word in English, like a fellow. And I'm just finishing my master's degree, and I will do a PhD in September. I work on indicators and P4P on research work.
Annelies van Linde, GP in Belgium, and I'm working for Thomas Medica, the scientific college for GPs, and there we are offering GPs a program for quality improvement by getting the coaches buying their practice.
I'm Peter van Hamburg. I'm 20 years in quality business, and I did a PhD on practice visits, and presently I'm a policy advisor at the Dutch Association, which is more or less the union. But there I do the quality and collaboration and all that sort of stuff.
I'm a little bit out of breath because coming here. Perhaps this side and that.
Okay, sure.
I'm the next.
I'm Alex from Portugal. I'm a GP in the northern Portugal, and I also work for the Portuguese Association of General Practitioners, and I'm the Portuguese delegate at EQuiP. And I'm also doing some lectures in the University of Minho, and we have been doing some also coaching for some quality improvement in Portugal, and we're trying to do more research in quality in our university.
My name is Antonio Schneider. I'm head of the Institute of General Practice at the Technical University in Munich, and I'm also a GP, clear. My research areas are in parts also quality improvement, general practice, especially as I was working in Heidelberg by Joachim Sejani. And now I'm also a national delegate for EQuiP.
I'm Dirk Evans from University of Kent. I'm a full-time professor since half year, and I supervise research on the crossroad of quality assessment, chronic care, electronic medical records. And I try to have some overview of the daily practice of quality assessment and some research.
So Canada,
Germany,
Portugal, Belgium, Holland, Belgium, France, Norway. Pretty good. Pretty good. That's amazing. Okay, so what I have a table here, and I think the most proud I am is the tablecloth, which is the new way of doing posters. You can wrap it in your suitcase and bring it along and use it for a tablecloth and hang it up, and they even have magnets over there that you could hang it with, which would make it really good. And I learned that at Wonka. I saw people who had brought them at Wonka, so great thing. I brought 3 books along, which are just to show you, and I'll put them on the table here so that people can have a look at them. And I have some bookmarks. Everyone can have a bookmark, which at the back gives you an overview of our categories, and some cards over here. And I have handouts here of our key features of our book. And I have some slides that I'd like to go through, and we can stop at any time and talk. So feel free to interrupt as we're going along, and you can just improvise. Okay? So first of all, I'd like to make a few acknowledgements because I haven't done this work on my own. I have worked very closely with Linda Hiltz, who's a family practice nurse, who has a master's in education, and who's really good at helping create the indicators and write the sections, has been a great assistant to me. And McMaster University Department of Family Medicine is where I work. I was chair from 1996 to 2006, and during that time I recruited a family physician, David Price, who's now the chair, and he has been a consultant on the project, and he's moving forward with the project provincially. I focused mainly on the indicator in the book at this stage. And also the Ontario College of Family Physicians. We have about 13,000 GP family physicians in Ontario. We have a population of about 13 million people. And so we have a college that has first and foremost quality as its key objective. And the college really is responsible for the curriculum, training, and continuing education of family physicians. We also have an association, which is like our union, the Ontario Medical Association, and they have a section of general family practice. And they, over the 10 years, have been very resistant to bringing about any kind of major quality, but they've come along and a long way, and now with the book in their hand, they're actually major advocates of the project, which is an interesting change and an interesting lesson in persistence. So everyone knows where Canada is, and this is where Ontario is in Canada, and it's a pretty big place. Most people live around the dark blue lakes at the bottom. Near Toronto, kind of this area here, and yet this area up here, which is probably equivalent to the area of France, has very, very few people living in it, but communities scattered all over the place, especially Aboriginal communities with Indian people living there. And the healthcare system in Canada is such that there are 10 provinces, and each province controls its healthcare system, except for Aboriginal people who have a treaty with the Crown, and their healthcare is covered by the federal government. So not only are they disadvantaged because they live so far away, but they're also terribly disadvantaged in terms of the kind of health care that they get. And there's a big initiative to try and improve the health care of those who are underserved or never served in the whole process of developing quality. So this is close to where I live. If anyone wants to come and visit, they're welcome. The most fantastic waterfall in the world, Niagara Falls. You can go there a million times, and it's always an absolutely inspiring experience to see the power of the water. And when I first came to Canada, I lived in British Columbia, and I lived 300 kilometers from Vancouver, in a little place called Rock Creek. This is Rock Creek, very different to where I live now. And I had a little clinic. Initially, the clinic was in this 100-year-old hotel, and then they built a clinic here. So when this picture was taken, there wasn't a clinic. Built a clinic here just when I arrived in the community. And there were only 300 people who lived in town, and 5,000 people in the area that I covered. Very different rural experience, and I practiced rurally for 8 years before I went into academic family medicine. And I think my first experience with quality had to do with having my first child. This is Jessica with me many, many years ago in Rock Creek. And, it's kind of like starting your first practice, having your first child. You're kind of very nervous about how much you can do for this child. And in the end, what was worthwhile, and how do you evaluate whether you were a good parent? And what did you put in place in order to make sure that you were a good parent? And I think probably we're all involved in that kind of quality all of our lives. So I wanted to talk a little bit about the book, give you a bit of an overview, how to get started with the book, how to use the book, and then we could have some discussion about similar tools that you have in your place and how useful or challenging they are to use, and whether this has features in it that you would find useful and helpful. And then I wanted to talk a little bit about some of the philosophy behind this book, about its open access, how useful the categories are, the indicators, the criteria, the links that we have. Are there any other things that anyone else was hoping that they would hear at this workshop?
Just a question, because I was curious when I was first made aware of this book last year. How can you produce that in an academic surrounding payment and wages and this is mine in an open access way?
Okay.
If you can include some of that,
Yeah,
I would be very happy.
definitely. Okay. So, it's been a long, long journey. And it started not as long as some of you have been. You look even like you've been in it longer than me. But it started in about 2000 when I was chair of the department at McMaster, and I got a letter from a young physician in Scotland, a guy called Ronald McVicker, who said he'd heard about McMaster and he wanted to learn about small group teaching and problem-based learning, and could he come and spend a year at McMaster. And if we're interested, he has some experience as a master assessor in the Quality Awards program in Scotland. And he could share with us the tool that they've developed and some of the experiences that they'd had. And I said, yay, yeah, sure, come on over and work for free and, and teach us all about these things, and we'll share with you what we do at McMaster University in problem-based learning and our curriculum, and which is only a 3-year medical curriculum. So he came along and he pulled together a group of family doctors in the city of Hamilton. There were about 10 of them, a few men, a few women, a few that were in solo practice, a few that were in group practices, and they met every couple of weeks and over David Price's kitchen table, and they had beer and talked about indicators. And they looked at the Scottish, this was before QuAF, and in lead up to it, they started the quality team development in England, and they looked at the indicators for this quality awards program that they had, and said, well, we're different in Hamilton. We all work in hospitals, we deliver babies, we look after palliative care patients, we look after children. There's a difference, and these indicators don't show that kind of difference. So they started changing the indicators. We went to the ministry and said, okay, now we have a Hamilton book of tools. Would you give us some money to test it? And the government said to us, no, we don't believe that Hamilton's tools will be useful. We have to, or that Inverness in Scotland had anything that was useful. We have to look at the whole world and come back and tell us what you recommend.